Okay, so today we want to do an examination of a woman who has postpartum hemorrhage, and now we want to manage this woman. We've assessed this woman, we've realized that the uterus is well contracted, and then we also noted that the bladder is empty. So before we have done the other measures, last time we did aortic compression, we've massaged and we've given the uterotonic so that we can control the bleeding, but the woman is still bleeding. So today we want to look at how we can suture this woman. Probably the bleeding is occurring not due to uterine atony, but the bleeding is occurring due to trauma of the genital tract. So basically, before we look at how we are going to suture the woman who has trauma to the genital tract, I want us to have an overview of how we can perform an episiotomy. So an episiotomy, it's a procedure that is done to help widen the genital tract so that when it is wide, a big baby, or when you have a presenting part that is bigger than the normal size, the diameters are larger, then they can easily pass through the vaginal canal. So basically, I'll just run you through briefly on the basic anatomy that we need to take into consideration. So for example, if we said that this is the perineum of the woman, isn't it? Mm-hmm. So with this woman, when we look at this as the perineum of the woman, we find that we have this baby here that is in this position, and it's supposed to be delivered. Then we are going to realize that the pathway, the genital tract, is not wide enough to accommodate the birth of this head that is coming. For example, when you look at this one, you see that it's a posterior position, isn't it? The cephalic, we say it's an anterior, but the cephalic is pointing this side. So now how do we widen the birth canal? Maybe it's even a breech delivery. We want to widen the birth canal. So we are going to perform an episiotomy. So when we talk about an episiotomy, it's the opening, or it's the procedure that deals with the widening the vaginal orifice. And normally, when we are widening this vaginal orifice, there's something that we're going to take note as we look at this episiotomy. We have different types of the episiotomy that the approaches we can use. We have what we call the mid-lateral. So when we have the mid-lateral. Then we have what we call the J-shaped. So when we talk of this mid-lateral procedure, when you look at this, is the vaginal opening, isn't it? So normally, on this vaginal opening, on top there we have the urethra, and then at the bottom here we have the anal sphincter. So we can either have the method where we are going to the J-shaped, where we start from the middle part there, we come, and as we approach towards the anal sphincter, we are going to go sideways. This one, if we want to make a generous episiotomy because the baby is big, or maybe we realize that it's a breech presentation, we don't want to, or maybe the baby is having difficulties with breathing, so I want the baby to deliver fast. So that when this is done, the baby can easily come this side, and then there will be that wider opening. Although this one, the danger is if you are not very skilled, you may proceed and end up cutting on the sphincter there, or the muscle surrounding the anal sphincter. Then the other method we can do the mid-lateral, and in the mid-lateral, we are saying that instead of coming down like that, then we are going to make our cut to go that side. So that when we cut from there, from the mid to there, then we go this side on the lateral aspect, then it is going to easily open up, and we are able to have a wider space and deliver the woman. So basically, that's the anatomy. I wanted us to be able to have a brief understanding of how we are going to perform the episiotomy. So now, when we are going to perform the episiotomy, what are some of the principles that we need to bear in mind? So basically, we follow the basic principles where we are going to ensure that we promote infection prevention techniques by using aseptic technique. The equipment that is supposed to be sterilized, such as the sheet faucet and the pack, are going to be sterilized. Then we also ensure that you can open sheet on page 372. Then the other thing is an episiotomy. As we look at some of the principles, we don't perform it anyhow. We have to wait first after the presenting part. For example, the head is now supposed to escape under the symphysis pubis, and then a crowning has taken place. So basically, when crowning has taken place, it means that the perineum, which is normally supposed to be 4 by 4 centimeters, has been stretched out, and in the process of stretching out, it has become about 10 centimeters long. And then even the connective tissue, like the blood vessels, they'll be so pressed so that when you look at the skin, it's almost transparent. Now, when the skin is almost transparent, it means that when you are going to cut, you are going to ensure you hardly cut through a blood vessel, and it will become easier for you to control the bleeding that could occur if you cut before the woman was adequately prepared. So those are some of the things we need to bear in mind as we are cutting the episiotomy. And then the other thing, that the indication for an episiotomy, as we mentioned, nowadays episiotomy is discouraged as much as possible. Reasons being that if you cut the woman unnecessarily, you've opened up the skin there, the tissue of the woman. You find that there are dangers that if the area there were any microorganisms, the fluids there, we could easily introduce infection to the woman, and especially now with the HIV. So with the advent of HIV, episiotomy is discouraged. It's only performed in DA cases. For example, you have a fetal distress, and you realize that the woman is fully dilated, the head has already entered into the pelvis, it cannot come out, isn't it? So you don't have time to take this woman for cesarean section, then you just do, whether it's a forceps delivery, you're going to deliver this woman in a shortest period of time. Okay? So now some of the indications, as we've said, when you have a larger baby, engagement has already taken place, and you know that this baby cannot easily deliver until you widen the space. And then also another principle which we didn't mention, which we should also take into consideration. When we are performing an episiotomy, we make sure that the woman's bladder is it's empty. You don't allow the woman to go into labor with a full bladder. Even when we come now, we start suturing, we should make sure that we empty the bladder. So now, on our trolley here, basically we anticipated we would have the proper delivery trolley, so that we have the other equipment that is necessary for us to deliver the woman. But now, since we are just focusing on the episiotomy and the suturing, we have just prepared equipment that will help us do those procedures. So put there, as I will be explaining the equipment, probably I'll also be doing what? I'll be opening up so that we don't waste so much time. So basically, we had cleaned our trolley before we started preparing. But now, for us to be able to prepare the trolley, we have equipment which is supposed to be on the top shelf and equipment that should be on the bottom shelf. But before we put the equipment on the top shelf, we need to make the top shelf to be surgically clean. So as we make the surgically clean, normally we use methylated spirit, and we also use some gauze swabs that will help us to make. So normally, I know I've seen others, they'll pour on top there, others they will do, but at the end of it, we bear in mind that spirit normally evaporates, so we want to avoid wastage as much as possible. So after we open, we close so that we reduce on the the evaporation. So we start, as we always say, start from the furthest point before you come to the point that is closer to you. So you make sure that you make your top shelf surgically clean until. So after you've made your top surgically clean, we put our delivery pack. I know in the books there, we might find they're talking of the balls. So instead of the balls, we are using the receivers. So we need to use the large receivers. So before we open our receivers, I'll just briefly mention what is on the top shelf, on the bottom shelf. So on my bottom shelf there, I've got a sheet of forceps which I'll use for opening the pack, and then I'll make sure that I have the surface that is already prepared for me to place my sheet of forceps after I've opened it up. Then I've also got two receivers there. So I've got one receiver there which I've put jig 1 in 6. It's the one that I'll use for putting the instruments after I've finished using them. Then I've got another receiver which I'm basically using for throwing used gauze swabs so that I don't just discard them anyhow. Then I've got this ball which I've put here. So basically after I clean, for example, after I finish scrubbing my hands, I'll be expected now to dry them. I'm using a towel which is placed inside the pack. Then I'll put it in the basin. I know I've seen a lot of students usually after they dry their hands, they just do that on the side. That is also attracting infection. Then I've also got another tray there with solutions, and also apart from the solutions there, I've got also the suturing material. So for suturing an episiotomy, since we anticipate that the skin for the mother it's not very hard, and there might be no need of us ensuring that the mother comes for suture removal. So where possible, we use disposable thread. For example, we can use a chromic cut, or we could use vernicreel. What is important, we use a round-bodied needle with, like this one, polyglacton 910, it's an absorbable suture. Or we could either have, like this one, Unsit, also it's an absorbable. We make sure that because the skin is soft, we use a round-bodied needle, and also we can also use chromic cut if we don't have these other type of sutures. So after we washed our hands, we prepare our equipment. This first part we can open with our hands. We make sure that the pack, we check when was it sterilized. In the world we have that tape, adhesive tape, which after sterilizing it changes color. Usually to be transparent, after sterilizing it becomes brown, so that it shows that it has been properly. It has to be higher than the trolley, not below the top shelf. So the inner drape, I'm using the sheet of forceps to open the inner drape so that I can prepare the equipment that I'm going to use. The one who was looking for gloves, did you manage to get some? So as we prepare, normally we are going to put the drapes. So depending at what stage we are going to prepare our pack. For example, we are preparing now, the baby has already been delivered, isn't it? So I could either have two drapes, or I'll have one drape which has a fenestil or an opening, so that the other parts of the mother are going to be properly covered. Then I've got also a pack that I'll use to control bleeding as I'm suturing the mother. I have gallipots here. I've put 3 gallipots. One gallipot has some gauze, the other gallipot has cotton wool, and this other one, it is plain. Now, because we want to combine with also examination of the cervix, I've put spongy holding forceps instead of the artery forceps. But in a normal delivery, we use the artery forceps because they are the ones that we are going to use to clamp the what? We use the artery forceps to clamp the umbilical cord for the mother. But when we are now examining the mother before we start suturing, like if we suspect that it's a cervical tear, we need the sponge holding forceps because these are quite long and you can easily have a good grip of the cervix without injury. So I'll separate them so that I'll put them some in the other receiver, and then the other receiver I'll use it for some use. So those are some of the equipment that is on top, and then afterwards I'll get my solution. So this solution, the Savlon 1 in 200, is the one that we normally use for valve swabbing. So I'll put it in this empty galley pot. Since we don't have the obstetric cream, we also use the same as the obstetric cream if we are going to be like when we are doing vaginal examination. Then also when I get so now for the episiotomy, normally we need lignocaine, which we are going to use as local anesthesia. So for me, before I scrub, I'll clean the bottom part to make it at least surgically clean. Now I'm not putting it on this drape, but I'm putting on like on this. You remember that the pack had 2 drapes, isn't it? So I'll put this bottle here on this drape, because I want to maintain this upper part as sterile as possible. So I'll open my suturing material in advance, or so normally I'll open my suturing material in advance. When I get this one, I should first of all check and ensure that it is not expired. So I check like this one, it is expiring in September 2026. So meaning that it is still good for use. So I can easily either open it and put it on my trolley there, depending on how. I may not open a lot because I don't know how much of that which is not yet the amount that I'll need. And then I'll also have my syringes. So normally, since I'm doing an episiotomy, I would rather I use the bigger one, the 10 ml syringe, so that I'm going to use it. So now I can open this and I'll place it on this one, because this one is sterile, isn't it? It's coming direct from the pack. So I am using 2 because the other one doesn't have one. Okay. So after I've opened that, then I'll also make sure that all the necessary equipment that I'll need to use, I'm able to prepare. Now after I've prepared the necessary equipment, the next thing that I should do now, I'm supposed to do what? I'm going to scrub. So basically, by now we know how long it takes for scrubbing, isn't it? We know how to scrub. So initially I'd use this towel here, but this time around, because I've done my surgical scrub, I'm going to use my towel there. I'll start by using the corners, and each corner I'll use it for one hand. So I scrub until I finish there, and then I'll also make sure that in between I've properly dried, because if I don't properly dry my hands, when I put the gloves, then you find that they are going to be wet. So after then I just throw my right there. I don't need to start hitting it with my knee. Isn't it? Okay, so after I've scrubbed, I'm supposed to wear sterile gloves, and then after I've put on my sterile gloves. I'll prepare this equipment now in readiness for my procedure. So I withdraw the lignocaine. Make sure that the lignocaine is not it's expired, and I'll use 1% of lignocaine, isn't it? Okay. So after I've withdrawn the lignocaine, I'm able to cover nicely, and then I'll just put there in preparation. Then I'll get my swabs. I should have assessed my mother, isn't it? So that I confirm how clean my mother is. Ideally, before we start the procedure, if she was delivering, we'd do what? We'd do our vulvar swabbing. So we assume that the vulvar swabbing has already been done, and now we want to perform the episiotomy. So I've withdrawn the lignocaine, and then after I've withdrawn the lignocaine, then I've also, I'll put some swab on my receiver there. Okay, so these swabs, they're the ones that I've also got this pack. Okay, so this pack is the one that, as I mentioned, I'll use it to control the bleeding so that I have good access. So to start with, I need the episiotomy scissors, the one that I'll need now to cut. So if you look at this one, you notice that the edges here in front, they are blunt so that we don't injure the mother. So we need the episiotomy scissors, and then if it was delivered, we're going to use the artery forceps. 2 artery forceps. These will basically use it for clamping the umbilical cord as we are delivering. And then we also need a Myers scissors. So Myers scissors, you know, the small scissors, the one we use for cutting the thread as we are suturing. And then we also need a stitch holding forceps. Okay, so after that, we need to also open so when you look at this one, you notice there's a dent here. So this dent is indicating that this is where you can easily break this and hold that. Now when you are going to remove this, when we start now suturing the mother, okay, normally we remove the thread inside, isn't it, in preparation. So some of the sutures, you would find that there could be, this thread is not kept dry like the way it is. Normally they would keep the thread in some fluids. So I find that usually they would advise that there's nothing wrong by putting, it's just alcohol. After suturing, we can still put it there where we're suturing. It also helps in the healing of the wound. So we prepare our suturing material, we remove it, and then we are going to prepare adequately after we've performed the episiotomy. So everything is set, we go to the side. So since I've scrubbed, I'm wearing my sterile gloves, it means that I'm not going to touch the woman. When I'm going to scrub, I will inform the woman that this is what I'm going to do. So I'll request now my assistant to come and expose the woman. Remember, each and every moment, we maintain the privacy of our patient. So my assistant will need now to start the procedure. So we placed our trolley at the closest part. Normally would be on the right side of the patient, but because we put our patient in this position, so that we can have a wider view, all of us, isn't it? So we place our trolley where we can easily reach. So Mama, we've come now, as we promised, we want to help you deliver. So may you open and expose my mother. So now after she has exposed my mother, the other thing that we do now, we are going to get the drapes. So as I mentioned earlier on, like now we have the fenistil ones, isn't it? So since we have the fenistil ones, we drape the woman so that we just leave this part visible. Okay? So when performing the episiotomy, so we advise the mother to say, as it starts paining, you are going to do what? You are going to push. But since after examination I noted that the birth canal is not wide enough, I'll need to perform an episiotomy. But I want to do an episiotomy there just like that. I'll first make the area, I'll put topical anesthesia to help numb the area so that I can perform the episiotomy better. So I'll get my tray, my receiver there with the necessary equipment so that I can do the needful on my procedure, isn't it? Okay, so we'll start first and foremost just the performing of the episiotomy. I'll leave this one first and then I'll get it later. So you assess the mother, you do your vaginal examination and you tell the woman to push until when you see that now the head is no longer going back. Because usually as the head is rotating, it will come and then it goes back. You've seen how a tortoise behaves, isn't it? Yes. It not says you've seen it if the head goes back, isn't it? Until finally it comes now, the head is stuck there, it is no longer going back because, and it has stretched this area there. That's when we are going to perform the episiotomy. So before we start, we are going to do what? We are going to apply the lignocaine. So if, for example, I wanted to do the J approach of the episiotomy, I'm cutting down and then I'm going down like this, isn't it? So I'll start by making sure that if the line is going to be there, I will inject on the side there. I start by withdrawing to confirm that I'm not in a blood vessel, isn't it? Then I start applying the lignocaine. As I am coming out, I'm applying the lignocaine. And then after I go this side, then I'm going to go that side as well. Do the same withdraw, and as I'm withdrawing, I'm applying the lignocaine. Okay. Now to avoid pricking the mother continuous, okay, instead of completely you come out and then you inject. Normally, after you inject, as you are coming out, you are applying the lignocaine, and then when the tip is remaining, you don't remove it completely, isn't it? You just change the direction of the needle and then you start what? You check for blood and then you continue applying the lignocaine as you are coming out. Then after you finished applying the lignocaine, you wait for a minute or so for the drug to take effect. Then you are going to ask the mother, are you feeling anything? So sometimes you can still use even the tip of the needle. You don't prick her, or maybe it is like that, or otherwise normally after you've injected you don't keep, isn't it? So instead you can just ask the mother, are you feeling what I'm putting there? If the mother says yes, I'm feeling something, she's able to feel the needle, it means that the lignocaine has not yet taken effect. Then when she tells you to say that I'm no longer feeling anything, then you know that the lignocaine has done what? Has taken effect, and now you can start your episiotomy. So when doing your episiotomy, you're going to get your scissors, and then you stand inside. So when you are cutting, you don't want to injure the mother, isn't it? So you are going to put your fingers there so that they give you a direction. And then don't start as if you are a tailor cutting a cloth, isn't it? Because immediately you do that, you find that it will become ragged and it will give you problems with the suturing. You want to make sure that you suture her to be as back to normal as much as possible. So you are going to put your fingers in so that you protect, and then you push in your scissors there. So if you are doing a lateral one, you cut, isn't it? Then after you've cut, then you are going to go on the side like that. You create your J scissors. Your J, what? If you are doing a mid-lateral, you are going to just have one cut so that you have a straight cut, isn't it? So basically, after you've cut, you make sure that you have a swab in case of there's a bleeding. So basically, then the mother, you allow the mother now to push the baby out. Okay? So that as the baby is coming out, then you are able to easily move. So now, any questions or clarification? It is clear? Yes. Okay, so after you've made your episiotomy, it's time for you to do what? To suture. Okay? So remember, time has passed from the time you were able to do what? From the time you performed the episiotomy. So since this is plastic, we may just throw it in the other one. Then this one, which we have used, we throw it in the sharp box. Okay? So we get a fresh needle, then we are able to withdraw. Now, like the way it was, if I was delivering the mother, now I want to suture the woman. I should, because now delivering the mother means that I will deliver even the placenta and everything. And then after I've delivered the placenta, the mother has been delivered, the next thing is I'm going to insert a vaginal pack. Okay? So the vaginal pack, as I insert in the introitus, it's basically there so that it prevents, it is going to collect the blood that is coming out from the cervix. Okay? And then because of that, you find that here on the birth canal it is going to be dry, then I can easily suture the episiotomy. So before I left, I had put the vaginal pack, and now I come. So when I come back now, I want to reduce introducing infection as much as possible. So this drape, I've used it and it is what? Sewed, isn't it? So this drape, I can remove it, put it in the bowl there, and get a clean, fresh drape. If the linen, for example, maybe this mother, she had the first twin, isn't it? Now we remove the bed sheet which contains the first twin so that she lies now in a clean and comfortable position. Now as she lies in a clean and comfortable position, the next thing that we do now is we are going to suture the mother. So we get our needle holder, so that we are going now to prepare to do what? To suture. So we need to open up this and remove the suture. So we should have ensured that this is a round-bodied needle. So usually avoid as much as possible to touch the needle. So like now, I had put some gloves there, isn't it? So I would have changed these gloves. I wear now fresh, sterile gloves. But before I start the actual suturing, I'll also now again reapply the lignocaine. I'll reapply the lignocaine and follow through with what I did. Now after I've reapplied the lignocaine, I have to now start my suturing. And before I start the actual suturing, the next thing that I should do, I need to assess the mother. Okay? So that pack, if it is short, I remove that pack, and then I'm going to assess starting from the cervix to make sure that there is no tear on the cervix. And then from the cervix, I look on the lateral fornices of the cervix, and then from there, I'm going to come down on the walls of the vaginal canal and assess for any tear until finally I reach and check on the perineum and confirm that there's no tear. Okay? So the suturing we normally apply when you do an episiotomy. It's a similar pattern when you are suturing a woman who had a 3rd-degree tear. A 1st-degree tear, 2nd-degree tear, we can suture similarly. So we know that the layers of the perineum are 3, isn't it? We have the submucosa, where we have the skin, the epithelium. Then we have the superficial layers, and we have the deep muscles. So we have the superficial muscles, we have the deep muscles. So now, as we are going to suture, some of the principles we bear in mind when suturing is that we are going to ensure that the layers of the tissues are apposed, so that when they are apposed together, then the healing can easily take place properly. Okay? Then apart from that, we make sure that when suturing, we start from the apex of the cut. If it's a tear, for example, you have a tear here, isn't it? So we have to check and assess where is the apex. And then from the apex there, we are going to suture and start coming down. Now, because we have 3 layers, we start with the innermost layer suturing, right? So we have our thread and the needle, isn't it? So we are going to assess and find the apex, and when we find the apex, just above the apex, that's where we are going to push in our needle. Okay? So we push in our needle, for example, we do like that. So remember, we are saying that avoid touching the needle as much as possible. So when you push in your needle, then you are going to hold the needle and pull it using the thread ring. Then after you've pulled the thread, you are going to, so when you are suturing, those who are this side, you can go this side so that you're able to see, isn't it? So you make sure that you don't completely let go of the thread, okay? So when you are suturing, you make sure that you pull the thread, it is tight, but don't make it too tight again to injure the mother, isn't it? So when you are suturing the inner layers, you are going to use the continuous stitch. We know the continuous stitch, isn't it? So when you use the continuous stitch, we don't break and cut the thread. So after you've tied, then you are going to get your needle, then you are going to again, so you have your artery forceps. So for example, I have my artery forceps, so that the artery forceps will be able to help you to grasp the other side. Then when you are able to grasp it, then you easily are able to push in your needle, okay? So when you are suturing, because this is, you are looking at 3 layers, isn't it? You are not going to suture all the layers at a go, okay? You are not going to suture all the layers at a go, and then you do a continuous stitch. So after you finished, your artery forceps, you are going to use now to again help you grasp the other end. You are going to suture like that, isn't it? So now, when you are suturing in an episiotomy, basically what you do after you finished the inner layer, the innermost layer, we said that you are going to use the continuous stitch, okay? So that you bring the 2 layers opposed. Then after you finished, now you have done the continuous stitch for the inner layer, you go to the middle layer also, you are going to stitch, then you come to the top layer. So when you come to the top layer now, you are going to do intermittent stitch. You are going to do the intermittent stitch. So in the intermittent stitch, again you start from the apex there, Okay? Then from the apex, you make sure that then after you've sutured that one, then you are going to get your scissors. You are going to do what? To cut. So normally, one thing that is important when you are suturing an episiotomy, you should have what? You should have a very good light so that you are able to see properly. So even when you finish the middle layer, the next thing that you should do now, you have to check and see whether the walls are opposed. Because if the walls are not opposed, you leave a small pouch. You find that blood can easily bleed there, and you might end up accumulating, you end up creating a hematoma, and then you are going to lead to development of the infection. So when you are doing that, you have your forceps. You hold your forceps like that, then your forceps is helping to direct the needle, and then you are able to hold the needle, and then you are going to easily tie. But remember, avoid as much as possible holding the needle because of the danger of the tears that may occur. If you notice that the woman, she's now losing the sensation and she's feeling the pain, I know where we go, they'll say, we suture under operation. But we advise not to do that ourselves. So as you are cutting the threads there, you also ensure that you don't leave them long because they'll be uncomfortable for the mother. Okay? So usually in an episiotomy, there used to be what we used to call the Kampala stitch. Anyone who has heard of the Kampala stitch? So the Kampala stitch is the one where we suture in layers, isn't it? We start with the continuous stitch until we finally do now the intermittent stitch. So after we have sutured, we have finished suturing the mother, we ensure that we start from the apex, we end with the base. Okay? So we have the needle holder there, and then we are going to make sure that we hold nicely. Okay? So afterwards, you make sure that you cut the threads, and then after you've finished the suturing, you need to check and confirm that it's not too tight. Because if it is too tight, then the woman will have some discomfort, and then the woman won't be able to heal properly. You find that even the sitting now is the one that is exaggerated. Everyone knows that something happened, isn't it? We don't want everyone to know. It should be our own issue, isn't it? And always make sure after you finish suturing, unfortunately this one, the threads are coming out. When you finish suturing, you assess yourself, you should be able to say that this one, you are suturing where there's good light, isn't it? Okay, so after you finish suturing, you've properly sealed the episiotomy. The next thing you're going to check and make sure that all the tears that need suturing, they've been sutured. Then after you've done that, you are going to remove the pack. Then you assess, clean the woman. After cleaning, you get your pad and apply the pad, isn't it? Then you are going to talk to the woman. Explain on how to care for the episiotomy. For example, she should be using cotton pads. Ensure that the pad is changed frequently, and then she should also be bathing at least 3 times per day. Where possible, in the morning, the afternoon, and in the evenings. But in between, when she needs to maybe pass urine, you advise her to say as she goes, after passing urine, she makes sure that she dries herself cleanly and then applies a fresh pad. Then she should be able to assess. Then if, like now we have used the absorbable sutures, isn't it? You explain to the woman to say that we have applied the absorbable sutures, we won't need to do what? To remove the sutures. But after 6 days you come so that we are able to assess. But when she comes, she won't find you in labor ward, isn't it? You explain to her, say when you come, you're going to come to your postnatal ward. You also inform them so that even yourself you record, they are aware that the woman you performed the what? An episiotomy. So after you've given a health education, then these that you use, like the needle holder, you're going to place them in a jig 1 and 6. Then the needle that you are using, you're going to put it into the sharp box so that it does not cause any infection to anyone. That is basically how we suture an episiotomy. We perform the episiotomy and we suture the episiotomy. So, but the other thing that we need to do, for example, this woman had a 3rd degree tear, or maybe at the 2nd degree tear, or we did this episiotomy like the J-shaped episiotomy. After we finish the suturing, we need to also do a rectal examination. Pass our finger into the rectum so that we confirm that when suturing, we did not suture also the rectal sphincter. Because if we're zealous, we suture, we end up closing up even the rectal sphincter. The next thing that we have, we find that now we cause infection because they are the fecal matter. As they come through in contact with the thread, it will lead to tearing of the thread. Okay? So now the other part of the procedure which we wanted to do, also which we wanted to show ourselves, is as we are managing the woman who has postpartum hemorrhage, we realize that the woman is bleeding, the uterus is well contracted, the bladder is what? It's empty, and then we've also given the oxytocin or the other uterotonics such as tranexamic acid, then they are in effect. Now it means that this bleeding should be coming from somewhere else. And we suspect to say maybe this woman could be bleeding due to trauma. Now when we suspect bleeding due to trauma, we are going to examine the cervix. Now in order for us to examine the cervix, we need to use the what? The sponge holding forceps. Okay? So normally in this one, we would scrub, put on gynecological gloves, which will go up to the elbow. And then for examining the cervix, for example, this is the cervix, isn't it? So we assume that, where's the other cervix now? So now we want to examine this cervix for us, and then as we are examining this cervix for us, we are going to assume that our cervix is divided into how many parts? In 4 main parts, isn't it? So we have, according to our watch, anyone with a watch there? So we divide our cervix into 4 main parts. We have the 12 hours one, which is here. Then we have the 3, 6, 9. When you look at our watch, it starts from 12, 3, 6, 9, and 12 there. So this is the way we are going to divide our cervix. So what we do is we get the first sponge holding forceps. We are going to grasp the cervix here. Okay? Then we get the other sponge holding forceps. We are going to place it at 3. So after we've grasped the cervix there, then we are going to gently do like this, so that as we are doing like this, if there's any tear, we are going to see a tear that is somewhere here. Then after we've examined this part, we are going to get this one at 12, lift it and grasp now there at 6. And then from there now we are going to open. So as we are opening, you can see that the tear is here at 6, isn't it? Then we know that this is where we need to switch. Now when it is at 6, we have to be cautious. Instead of just checking here in front, we have to check also inward, because sometimes, especially the posterior tears, they can easily be there and then it is extending into the uterus inside there. If it extends into the uterus, it means that this woman has to have a what? A hysterectomy. So after we've put there at 6, then we are going to get this one which was at 3 and place it now at 9. Then afterwards, when we place it at 9, we are going to assess this area. We start from inside, coming out and confirm that there is no tear. And then we grasp this one at 6 and place it at 12. Then we are going to examine this part between the 9 and the 12. Then after we have finished, we are going to remove these dissecting forceps and let go. So that now we dip them into jig 1 in 6, and then depending on the findings, if for example we had a tear there, we may not remove them completely. We will come and grasp this area so that we create a clear environment. Normally this should be done if we are at a clinic. As we are referring, we are going to pad this woman, refer them to the hospital so that it can be sutured in theater under anesthesia. We indicate we've done a cervical examination, and according to our findings, we found that there was a posterior tear, and we want further examination under anesthesia and suturing in theater so that they'll suture. But if you are at a clinic where you are just alone, and you know that for you to reach the health center or maybe the hospital, you need another 8 hours. You've sent for the driver, the ambulance is not coming, the tear is here, then you can suture. Now the suturing is similar to what we follow through. You use a round-bodied needle with an absorbable suture. You are starting from up there. So as you are starting from up there, for example, this tear is starting from here, isn't it? So you are going to grasp the upper part on the apex there, about a centimeter away from where the tear is starting from. You start suturing, and then you follow through. You suture a continuous stitch inside, and then after the continuous stitch, now you are going to close with the intermittent stitch on top there. Any questions? Any questions? So after you finish, again, if there was a pack which you had put, you remove the pack. Then after you removed the pack, you are going to again, because when you are suturing, probably you could have also hit the mother, there could be some bleeding or there's what. Before you leave, you are going to again do some vulvar swabbing, so that after you've done the vulvar swabbing, then you are going to apply the pad, and then after you've applied the pad, then you make the woman comfortable. Okay, you make the woman comfortable, and then you are going to discard your trolley accordingly. Okay, so basically that's what we do when we are managing a woman and we want to suture a second degree or third degree tear or an episiotomy.